Okay, good afternoon, everyone, and welcome to Cardiology Grand Rounds. It is a great privilege to have all the way from Paris, France, Dr. Marc Humbert here today. Dr. Humbert and I have known each other for many, many years, maybe decades, actually. He is really one of the world experts in not just pulmonary hypertension, but also asthma as well. Can you imagine being a world expert in two different diseases? Marc has a basic science lab, and his lab has made many important contributions to the pathogenesis of pulmonary arterial hypertension, the role of inflammation, genetics, and they also have a very large patient population in France, and he was the lead investigator on the French registry and has many important publications from that. He is really a leading authority and is on pretty much every steering committee of every clinical trial in pulmonary arterial hypertension right now, probably the most important expert in the world on pulmonary arterial hypertension at this point in time. And in addition to all of that, very recently, he became the dean of his medical school. So now, despite wearing all of these hats, he's an incredibly kind gentleman, one of the nicest people and most courteous people you'll ever meet, one of the hardest working people you will ever meet. I will tell you, when I email Marc, I get a response within minutes to hours. This is just always the case. I'm pretty sure he has that gene where he only needs 3 hours of sleep and he can just get massive amounts of work done. It's really impressive. So Marc is here today. He and I are going to CVCT together later, and he will be speaking again there. Today, he's talking about targeting the TGF-beta pathway in pulmonary arterial hypertension. So please help me welcome Marc to the University of Michigan.
Thank you. Thank you very much, Val, for the very kind invitation, very kind introduction. And for me, it's a great pleasure to be with you, because this place is a very important place in medicine. Of course, you all know that. In cardiovascular medicine, of course, but in pulmonary hypertension, it's one of the key places in the world. So hearing Valerie McLaughlin mentioning all these good words about me it's a great privilege, and I share the same compliments with Val. Val is a person of real importance in the field, and it's always a pleasure to work with her. So I'm from Paris. I'm from the south of Paris, and a university named Université Paris-Saclay. This university is really prominent in mathematics, in physics, and in medicine for some important aspects like oncology and rare diseases. That's the reason why we are usually quite privileged to work in such a university where interdisciplinarity is a key word, where we can develop new solutions for patients and partner with major universities like yours in our field. So I am, as Val said, the chief of the Respiratory Division and Intensive Care Division, which is in fact the French Pulmonary Hypertension Referral Center. And we have a network which takes care of all the patients in our country. Our country is around 68 million inhabitants. So we have a registry with 18,000 names, and it is an open registry which never stops. So it helps us with Olivier Sidbon, David Montagny, and others to have very good data. And linked to that, we have a biobank, because we do, of course, biobanking of our patients, and we do transplant our patients. So we have the whole spectrum of information, from data to samples and to whole lungs. In the lab, which is like NIH supported, it's INSERM in France, means NIH, we have access to animal models and to facilities which allow us to test and treat experimental models of pulmonary hypertension. So I will try to share with you today a very focused topic on the transforming growth factor beta superfamily in PH. As you do follow the topic, it is certainly one of the most important recent advances in the field. And with Valerie, we have been key players in the recent development of this new aspect of pulmonary vascular medicine. So I have disclosures to report. I'm involved in many advisory board and randomized control trials, and have relationships with most, if not all, of the companies involved in the field. And on top of that, some of these companies partner with us in the basic and translational laboratory. So one of my tasks at French level and European level is to disseminate knowledge and to update knowledge and to update guidelines. And I was very much involved at the European Respiratory Society level and European Society of Cardiology level. And every 5 to 7 years, we do produce guidelines. And the guidelines are usually timed, synchronized with a world symposium on pulmonary hypertension. And every 5 to 7 years, we have one world symposium and 1 or 2 years after European guidelines. And these European guidelines, they really set the scene and inform the community on how to diagnose, how to manage, how to organize pulmonary hypertension diagnosis and care. So that's really a privilege to be lead author of the last European guidelines with many of my friends from many European centers, including patients. And patients are authors of the guideline, and that's very important to emphasize. When you look at one of the important conclusion and the central figure of the pulmonary hypertension guidelines, the first take-home message is that pulmonary hypertension, it's not a disease. It's a hemodynamic status defined by a mean pulmonary artery pressure above 20 millimeters of mercury. And many, many patients worldwide, especially patients with advanced heart disease or advanced lung disease, do present with elevated pressure. And these patients, in fact, represent around 1% of the global population on Earth. That being said, there are subcategories of pulmonary hypertension, which are pre-capillary, with a normal wedge pressure, way below 15, who are characterized by either persistent obstruction of the small pulmonary arteries due to pulmonary embolism, like here, or remodeled vessels, like here, due to usually genetic or associated conditions. So the group 1 and the group 4 pulmonary hypertension in the classification, they are not common diseases, and they have to be identified out of the pool of patients who do present in your clinic with elevated pulmonary pressure. So one of our tasks when we write the guidelines is how to screen, how to identify, how to manage the rare variants of pulmonary hypertension. And what is really interesting is that these rare variants are the causes of pulmonary hypertension for which recent years have witnessed the most important advances. And if you look at the treatment options in pulmonary hypertension, for group 1 PH, what we call pulmonary arterial hypertension, you have 15 drugs approved worldwide for this rare condition, affecting 15 to 50% per million inhabitants. So in a country like France, it means that you have a few thousands of patients hanging around, but they are detected and they are treated in referral center. France is organized in a way where you cannot treat properly these patients outside of a referral center. And that's a strength of our system. But on the other hand, it can be also a barrier for access to care. So we have to organize that in a proper fashion in order to advocate for patients to be identified in the community and directed to the referral center. The same applies for group 4 pulmonary hypertension, where we have surgery, angioplasty, and drugs available for management of these patients. And for group 4, I will not discuss it too much today, but we do not oppose surgery, angioplasty, and medical management. Every single patient is a candidate for multimodal approaches, which can combine 2 or 3 of these options together. But let's move now to pulmonary arterial hypertension and advances in science and management. The major improvements in management of group 1 pulmonary arterial hypertension derived directly from the better understanding of the impaired endothelial-dependent vasodilatation in these patients. We know for sure that in pulmonary arterial hypertension, there is a decreased ability to dilate and an increased ability to constrict at the small pulmonary artery level. And it's really interesting to look at the history of medicine, and you see many, many names, prominent names in the field of pulmonary vascular biology or vascular biology have been awarded the Nobel Prize in Medicine and Physiology because of their description of the key discoveries concerning prostaglandins, concerning nitric oxide, and concerning endothelin-1. And when you look at these major players in the field of vascular biology, their discoveries within years has been translated to a rare disease named pulmonary arterial hypertension. So when you see, for example, here, Sir John Vane, who was awarded the Nobel Prize in Medicine and Physiology in 1984, less than 10 years after his Nobel Prize award, there were patients treated worldwide with intravenous prostacyclin. And the same, of course, for nitric oxide giants who helped the community to develop phosphodiesterase type 5 inhibitors and guanylate cyclase stimulators. And the same applies to endothelin-1 with the development of endothelin receptor antagonists. So big, big science, major discoveries, and really people thinking outside the box, discovering key pathways which would be good targets for drug development. And the drug development has been very fast. And thanks to these very clear targets identified by these scientists, pharma and investigators have been able to develop solutions like intravenous epoprostenol with the late Robin Bast article published in the New England Journal of Medicine in 1996, or PDE5 inhibitor with this paper published by Nazareno Galli and colleagues in the New England Journal of Medicine, or endothelin receptor antagonist with this article published by Louis Rubin and colleagues in 2002 in the New England Journal of Medicine. So what I like in this introduction is that when you understand a mechanism, and when the mechanism is well described, you can target it. And if the mechanism is meaningful in a condition, well, when you target it, it should lead to meaningful outcomes. And usually the meaningful outcomes in these studies, it's exercise capacity. It's rarely survival. And survival is not firmly improved, but in randomized controlled trial in all the drug development in PH, although we believe that survival has improved with the development of drugs in our field. But in these studies, it was mostly exercise capacity and other surrogates of survival, but not direct evidence of survival. So we were invited several times to write review articles, and we made, since 2004, very, very simple cartoons with a vessel which is remodeled on the top, either a real vessel here from a patient in Paris, or a cartoon of the same here, and always the 3 pathways. And the 3 pathways are involved in the vasoconstriction, vasodilation, imbalance. And we know when you interfere with vasoconstriction or vasodilatation, you have some kind of anti-proliferative action. Not major, but it's not only vasodilatation, it's also anti-remodeling. And the big change in 10 years' time on the left and right, the big change was not identification of a 4th pathway. It was only refinement on how to interfere with the pathways. And to be frank with Valerie McLaughlin and colleagues, the big advance in the last 10 years was how to combine drugs together, how to combine drugs together, when to combine them together, and try to improve the best standard of care for our patients with three options of targets. So that was our history. And in the guidelines, we wrote very clearly, and we are not going to go too much into details, but we wrote very clearly that incident patient presenting with group 1 pulmonary hypertension should be risk stratified. And depending on the level of risk of death at 1 year, you should propose either 2 or 3 drugs in combination. And then the patients are followed up and sequentially combined if needed, or candidate for lung transplantation if the patients are eligible. So the guidelines are rather simple. And next year, Valerie and others are going to work very hard on how to update the treatment algorithm with new drugs in development. And it's a great privilege to have drugs in development in a rare disease like pulmonary hypertension. But now the introduction is over, and we have to think outside the box. Why do our patients develop pulmonary hypertension? Is it a disease of abnormal vasoconstriction, or is it more than that? It is more than that. And we know for sure that vasoactive mediators are meaningful. And when you target them, you improve outcomes. Okay, we have discussed that already. But there are other abnormalities in our patient. And what is really important when you look at the vessel, and it was already in our cartoons in 2004 and in 2014, there is vascular obstruction, which is mostly due to remodeling, not to constriction. Maybe there is some kind of constriction, but what matters very much is that you have remodeled vessels. On the left-hand side here, you have a normal vessel, which is thin, which is very compliant. You can increase blood flow from 5 liters per minute cardiac output to 25 within minutes without changing your pressure. You recruit, you inflate. It's very, very, very friendly. You don't increase the burden on the right heart. But on the right-hand side, you have a remodeled vessel. And the remodeled vessel is remodeled in many ways. You have a multi-layer of endothelial cells. Normally, you have a single layer of endothelial cell. Here, you have multiple layers of endothelial cells, which are dysfunctional. They produce abnormal mediators. On top of that, you have proliferative smooth muscle cells in the median. So the vessel, which is normally compliant, is in fact becoming non-compliant and very resistant to flow. And on top of that, the adventitia is infiltrated with inflammatory cells, and it's fibrotic. And with Dr. Khanna in the room, we have lots of scleroderma patients with remodeled vessels developing pulmonary hypertension. And the adventitia of these patients is very rigid, very fibrotic, with endothelial to mesenchymal transition. So what's happening in the vessel is really abnormal. And there is a key word here, it's growth factors. There is something wrong with growth factors, many growth factors. You can say transforming growth factor beta, like in my title. I could give a talk on PDGF, it would be broadly the same talk. But here we have several growth factors which are disturbed in the setting of pulmonary arterial hypertension. And these disturbed growth factors are obvious targets for drug development. It doesn't mean it will work, but they are obvious targets. The same way that the pioneers in the field said vasoconstriction is an obvious target. Here, remodeling is an obvious target. And maybe one day inflammation or other things will be, but here growth factors are very important. And on top of that, you know the classification of pulmonary arterial hypertension, there are familial cases. And when you have a condition with familial cases, usually you have a causing gene. And the causing genes usually shows you the way to the solution. Some of you work in cystic fibrosis. You know how beautiful treatment development has been in this field. I mean, our patients are delisted from transplant program It's a magnificent. And here we have genetic causes of pulmonary hypertension. And let's have a look to what's going on in terms of genetic problems. So we have in familial cases of pulmonary hypertension, a major mutation, which is an autosomal dominant mutation in a gene named BMPR2. It stands for bone morphogenic protein receptor type 2. It is a member of the transforming growth factor beta superfamily. So it is a type 2 receptor member of the TGF-beta superfamily. So my long introduction told you, please show me the way, and growth factor should be a key word. And here you have familial cases in PAH with genetic mutation in transforming growth factor beta superfamily. So it would be, I would be blind, we would be blind if we were not insisting on understanding what's going wrong with this pathway. And let's have a look to what does this pathway do in physiology. In a physiologic status, this pathway is involved in what we call pulmonary vascular homeostasis. And if you look at BMPR2, it is a type 2 receptor of the TGF-beta superfamily. It partners with TGF-beta type 1 receptor, and the ligands are members of BMPs. And when you have two type 2 and two type 1 receptors together, it makes a viable receptor for BMPs. And in normal status, it will phosphorylate SMAD158, and it will have an anti-proliferative action. So in pulmonary vascular homeostatic status, you don't have excessive, you don't have a defect, in BMPR2 transmission. So BMPR2 is a kind of gatekeeper of a normal pulmonary vessel. And it's always good to understand the balance in biology. And there is an opposite balance, which is a balance with other TGF-beta superfamily members with a type 2 receptor named activin receptor type 2A and type 2B, and type 1 ALK457, transducing the signal through SMAD2/3 phosphorylation, and this pathway is pro-proliferative. So in pulmonary arterial hypertension, there is a breach in the balance between the anti-proliferative and the pro-proliferative pathways, and it results in a reduced anti-proliferative signal and an excessive pro-proliferative signal. So everybody thought in the past that the future development of drug will be drug repairing BMPR2, but if you think a little bit broader, it could be also drugs diminishing or decreasing the activin signaling pathway. So there were two ideas, two visions. I was open to the two visions, but it was not mandatory to focus exclusively on BMPR2. The whole system shows that it's more complicated than that, and maybe acting through a decrease in activin signaling pathway could be a right approach. So you see here with a red cross, that's what's happening in patients with PAH, especially familial PAH. There is a breach in BMPR2 transducing signal, so there is less SMAD158 phosphorylation, and there is an imbalance towards the pro-proliferative pathway through activin receptor type 2. Very simple story. And if you look at the keywords on the left, in PAH, there are several evidences in favor of an imbalance in this pathway. And clearly, we can think that there should be some targets to discover if you can restore the proper homeostatic balance in the small pulmonary vessels. So let's move on a little bit and let's go back to the lab. So on the left, it's a Ph.D. student from my lab, Aurélie Hautefort. She's very young. She's less than 30 years old. She successfully presented her Ph.D. a couple of years ago, and she published in Circulation this article, which is interesting. It's the one on the left. she showed that when you take rats are better animals for pulmonary hypertension modeling versus mice. The mice don't develop severe pulmonary hypertension. The rats can develop severe pulmonary hypertension. So we created BMPR2 mutated rats. And in humans, only 20% of people carrying BMPR2 will develop PAH. It means that you need a second hit. The second hit can be maybe exposure to a diet pill or maybe developing an inflammatory condition, etc. So here the rats were studied, and BMPR2 mutant rats, they did not develop pulmonary hypertension, but they had pulmonary vascular remodeling. So they had a tiny bit of remodeling of the vessels. And in collaboration with our friends from Stanford University, Marc, Nichols, and colleagues, we played with the same rats, and they added some inflammatory triggers. And what they showed is that the rats who had silent bone morphogenic protein receptor type 2 mutations, meaning no phenotype, when you expose them to an inflammatory trigger, they did develop pulmonary hypertension. So in fact, the second hit theory was proven. Spontaneously, BMPR2 is not enough, but if you develop a pro-inflammatory status, you may develop pulmonary hypertension. Then we are lucky in our field because we travel a lot. So then we partnered with Kobe in Japan, and these colleagues who are part of the lab of the guy who discovered endothelin 1. It's the same lab, Yanagisawa lab. And with Professor Emoto, who is a good friend, we decided to partner together. And we did two studies, very simple. It's published in Nature Communication. Study number one, we did not focus on BMPR2, the anti-proliferative pathway. We developed a study on activin pathway, so the pro-proliferative pathway. And when we deleted the inhibin A, so if you wish, activin A in rats or mice, we were able to prevent chronic hypoxia-induced pulmonary hypertension. So nice story, yeah? The BMPR2 mutants, they needed a second hit to develop pulmonary hypertension. And here, the other pathway, when you block it, you become less prone to develop pulmonary hypertension in hypoxia. And when we activated the inhibin A, so activin A, it led to pulmonary hypertension, and it exacerbated hypoxia-induced pulmonary hypertension. So very interesting story. And then we developed this little cartoon. Primary hit is certainly in genetic forms of pulmonary hypertension, a decrease in BMPR2 function. But people in the UK and in the US and in Europe and in Japan demonstrated that even when you don't carry a BMPR2 mutation, in the setting of pulmonary hypertension, you have decreased BMPR2 activity. So it's not always genetic. It's sometimes only the function of BMPR2, which is not good. But it's not enough to develop pulmonary hypertension. You certainly need the second hit. For example, we were very lucky to follow during more than 10 years a cohort of French subjects carrying BMPR2 mutations without pulmonary hypertension. We followed them year per year per year per year. And we realized that the males were 3 times less likely to develop pulmonary hypertension over time versus women. And it confirms the data from the Vanderbilt group, which showed that you are 3 times more likely to develop pulmonary hypertension in the setting of BMPR2 mutation if you are a female. So hormonal factors, maybe factors related to pregnancies with overflow, etc., shear stress, but also inflammation, autoimmunity, etc. So we are like in cancer. We have a transforming growth factor beta environment, which is disturbed, but you need a second hit to develop the condition. And the condition looks like cancer, but it's not cancer. It's only proliferation, but no metastasis. So let's move back to the French biobanking, and the French animal facility. And you see here on the left, it's the French patients with pulmonary hypertension, and it's very simple measurements in the serum of activin A. And you see that activin A in PH is higher than in control subjects. And in every single animal model of pulmonary hypertension we have developed, there is an increased expression of activin A. So activin A seems to be overexpressed in humans and in preclinical models of pulmonary hypertension. And this is published in Circulation. You see here, I'm going to focus on something easier to read. So here you have PAH, bottom left. And here you see pulmonary artery smooth muscle cells with SMAD2/3 phosphorylation. You remember SMAD2/3 phosphorylation? It means that the activin signaling pathway has been switched on. So in humans transplanted for PAH, you see that the endothelial cells and the smooth muscle cells, they switched on the activin pathway. So that's interesting. And we have many other cartoons here showing that activin A is overexpressed, not only in endothelial cells and smooth muscle cells, but also in macrophages, bridging the hypothesis between inflammation and remodeling. And that's, I think, a major information. So this is where we stand. We know that the TGF-beta pathway is an obvious target for drug development. So you have two options. Let's start with the BMPR2 option. So the BMP-GDF branch, I put it in green. So it means that when it's activated, it decreases proliferation. So here, when you have patients with defective BMPR2 pathway, you could improve the outcome in theory with recombinant protein pushing harder on the pathway or activators of the pathway, like in CF, like in cystic fibrosis, or gene therapy. You could restore a normal BMPR2 function. So everything has been tested in preclinical models with some success. Then let's move to the red. So red is activation proliferation. So that's the activin pathway transmitting the signal through SMAD2/3 phosphorylation. And here you can block the pathway. So rather than putting recombinant proteins, here you block the activin A with either neutralizing antibodies, which is classical, like in asthma, anti-IL-5, or you block the ligand. So you make a kind of chimeric drug with the receptor of activin, and you bind it to an immunoglobulin G1, so it will trap the activin like a neutralizing antibody. It's like in rheumatoid arthritis, etanercept, blocking TNF through a receptor. Or you develop an inhibitor of the pathway. There are many. Or you give antisense rather than gene therapy. It's antisense. You block the signal. So a lot of things could be done. And clearly, what has been done first is to rebalance BMPR2 and activin receptor 2A mediated signaling through rebalancing of the pro-proliferative and anti-proliferative pathways with a ligand trap. So the ligand trap is named sotatercept. So I have disclosed in my introduction that I have links with the company which is currently developing this drug. It is a biologic. So like in asthma, like in many other conditions, it is like a monoclonal antibody. So it's given by subcutaneous route once every 3 weeks by repetitive injection. So you see what it is like. It is like a little trap. So it is the modified activin receptor 2A receptor, and it's bound to the human IgG1. So with this little trap, this is a situation in PH, not enough BMPs, too much activin, and with the trap, you try to restore a physiological status with a well-balanced homeostatic TGF-beta pathways working well together. So our friends from Brigham and Women at Harvard Medical School, Paul Yu and his colleagues, many colleagues who worked very hard on that. He tested this ligand trap in preclinical models of pulmonary hypertension. And he showed very clearly, you see that's my cartoon before, in pH, this pathway is defective, but this pathway is taking the lead. And with these little traps, you try to rebalance the SMAD2, 3, SMAD1, 5, 8 targets. And here in the animal models of pulmonary hypertension, he showed that this agent improved hemodynamics, right ventricular hypertrophy, right ventricular function, and pulmonary arterial remodeling. So it sounds good, but there are many, many drugs in development which show the same thing in animal models. Animal models are models, and they are not human disease. So we went very fast, and with Valerie, we shared, in fact, the first authorship of this paper, and Dave Badesh was also a key member of the program with many others. And we demonstrated in a phase 2 program, randomized controlled trial, that after 24 weeks of sotatercept treatment in patients who are already treated with 1, 2, or most often 3 drugs for pulmonary hypertension, you can improve pulmonary vascular resistance in a dose-dependent fashion. So for us, it was 3 years ago, it was an eye-opener. These patients, you see, they were 56% of them on triple combination therapy, and we all thought that they had everything they could have to decrease PVR, but rebalancing the TGF-beta pathway and interfering with activin receptor type 2 decreases the PVR by 20% or 34%, depending on the dose, 0.3 milligram per kilogram or 0.7 milligram per kilogram, plus, it's echoing. Yeah, it's better now. So there is an add-on benefit, okay? Add-on on top of best standard of care. Exactly what we want to have. It's not a me too, it's an addition. And other endpoints were improved, walk distance, NT-proBNP, functional class, and there were some side effects. The most common ones were the side effect on bone marrow, because some of you working in internal medicine may know that interfering with the activin pathway can improve hemoglobin level in conditions like myelofibrosis of the bone marrow, etc. So it was not a surprise to see that 14% of the patients had increased hemoglobin count. It was an expected side effect, and we monitored that very carefully. Then thrombocytopenia was less expected. And it was the early stage. These were the most common side effects identified. And you see that there was an open label extension. The interest of the open label extension was to show that the placebo-initiated patients, they did catch up and they did improve after being treated with sotatercept. And the beauty of this study is that only 10% of the patients were in functional class 3. So meaning that after 18 to 24 months of treatment, 90% of the patients were in functional class 1 or 2, which is very, very important. But there were new side effects. And the new side effect is interesting, telangiectasia. So we I think, create hemorrhagic hereditary telangiectasia-like patients. And we have to monitor that very carefully. Telangiectasia, they look like spider navy, and they are really demonstration that when we rebalance the activin pathway in the lung, we disturb it in the periphery. And we have thus patients presenting with some dots on the face, on the fingers. It's not dramatic, but you will see later in the phase 3 that it can be problematic in some patients, and it has to be monitored carefully, and it's becoming an adverse event of special interest. Despite what is written on this slide, it's very likely that the activin receptor 2A ligand trap do trap BMP9, which is a key driver of angiogenesis and which could create telangiectasia when it's decreased in the periphery. So after the phase 2, of course, phase 2, it's proof of concept, but it was published in the New England, meaning that it attracted the interest of the community. There was a very important phase 3 program. And the first phase 3 is Stellar. It has been published this year in the New England Journal of Medicine. And there are 2 other outcome studies with patients included in your center. I know there is one cooking right now, but we have the privilege to offer this treatment in Hyperion in recently diagnosed patients not meeting the treatment endpoint, and Zenith, very advanced patients who are candidates for lung transplantation or death if they are not eligible. So these trials are very important, but I cannot discuss Hyperion and Zenith. So we discuss Stellar, which is a pivotal trial. And I'm not going to spend too much time because I think you know this study. It has been very elegantly presented on several occasions, but bear in mind, the patients in Stellar, more than half, 60% in fact, are on triple combination therapy, 40% are on parenteral prostacyclin, and most of the patients are on at least 2 drugs. So they are treated, and despite this treatment, they are in functional class 2 or 3, and they have a walk distance and NT-proBNP, which shows that the condition is not properly controlled. And the study is crystal clear, very simple, double-blind, placebo-controlled versus placebo, target dose 0.7 milligram per kilogram. You understand why, because PVR decreases more with the highest dose. And you see primary endpoint, traditional 6-minute walk distance, and then a hierarchy of secondary endpoint. You know, when there is a hierarchy, each one had to be positive to go to the next one. So the hierarchy was, so first 6-minute walk distance, and then there was change from baseline to week 24 in multi-component clinical improvement, in NT-proBNP, in PVR, in functional class, in time to death or clinical worsening, in low-risk stratification, and in quality of life according to the pH-SYMPACT questionnaire. So a long list of secondary endpoint, very brave study. And as you can see here, the patients were recruited very nicely. We were ahead of schedule. If I remember well, at the very end of the study, there was 1 randomization per hour, which means something. I mean, in a rare disease like that, it means that there was a lot of excitement. And the patients were the most excited. They wanted to be part of the game. So I'm not going to go through all the details, but this is traditional PH, younger, around the age of 48, mostly Caucasian, mostly idiopathic or heritable, mostly on double or triple combination therapy. And despite that, with a walk distance of 400 meters, high NT-proBNP, high PVR around 10 Wood units, and high mean PAP around 50 millimeters of mercury. And okay, it's once in a lifetime for me. The primary endpoint was critically improved by 40 meters. I'm not going to the details. There were multiple assessments of the primary endpoint, but you take it the way you wish. It was 40 meters more or less. And then the secondary endpoint in hierarchical order, and that's the most impressive part of the study. You see that the p-values are on the right. I'm not going to read through all the lines because it's a bit too much, but all the secondary endpoints were positive except the last one, which is one sub-category of the pH-SYMPACT on cognitive and emotional approach. This drug was tested during COVID time. There were some missing values in the quality of life. We discussed that with Victor this morning. And clearly, I'm very happy that even quality of life parameters, the physical impact and cardiopulmonary impact, were positive because that matters a lot. The between group reduction in mean PAP was 14 millimeters of mercury. And in fact, this treatment, when it reduces pulmonary vascular resistance, it reduces pulmonary vascular resistance, which is a ratio between pressure and cardiac output, exclusively through pressure reduction. So no change in cardiac output, but major drop in PVR, meaning that this drug is certainly quite specific on the pulmonary vessels. This is very impressive as well. The time to clinical worsening, it was not very long. It was 24-week study, and then the patients remain on drug or placebo until last patient, last visit. And you see that the curves separate very early, and there is a clear improvement, and the improvement was very important. There was 84% improvement in time to clinical worsening on drug versus placebo. So side effects. I told you the more we progress, the more we understand the side effects. So side effects now are getting more and more clear. So bleeding, mostly nasal bleeding, and we have to keep an eye on bleeding. Telangiectasia, you see up to 30% of patients have telangiectasia. Then increased hemoglobin by definition, and thrombocytopenia, and increased blood pressure, which doesn't mean much because our patients have low blood pressure. So the most common side effects occurring in more than 10% of patients were nasal bleeding, telangiectasia, and dizziness. Don't ask me why, I don't really know, but epistaxis and telangiectasia. So for those of you who are in internal medicine, looks like Rendu or Weber, HHT-like phenotype. So I'm closing very soon. So it's a relief for me to have a fourth pathway before I retire. So because we keep on showing the three pathways for many years, and you know, you are in the US, you know that the FDA is analyzing the data from the STELLAR study in order to approve it for treatment in your country by the end of March 2024, if everything goes well. So we can think a little bit outside the box now. On the left-hand side, we have the three traditional pathways, which mostly work on pulmonary vascular tone regulation, but also some kind of anti-remodeling effect. But here, I'm not going to read through all the possibilities, but the three pathways remain important. And this background therapy is very important for the treatment of patients. But on top of that, you can now target more directly proliferation and certainly stiffness of the vessel. And you can target these pathways through today activin signaling inhibitors, which are available only in randomized controlled trials today. So good for your patients if they can be recruited right now. And very soon, I hope, through usual care. So of course, we still work. And this is my last slide. We don't stop working. We have to understand better and better. I think sotatercept opens a new avenue. The new avenue is targeting remodeling in pulmonary arterial hypertension on top of vasoconstriction and vasodilatation. And there are some drugs currently tested. Some had dramatic outcomes in the right direction, some in the wrong direction. So I'm not going to go too much into details, but there will be other activin and GDF-directed treatments. The one I showed you in green and red, they are here to stay and they will be tested. Maybe they can refine, they can improve the treatment. Some drugs target serotonin. All of them have failed. And recently, the rodatristat data have not been convincing at all. So the serotonin pathway is not the prominent one right now, but it's interesting to understand why some patients treated with serotonin inhibitors develop more critical pulmonary hypertension. So that's something we have to understand. Then PDGF, you all know imatinib or seralutinib. So they are tyrosine kinase inhibitors in development, mostly developed by inhalation in order to avoid systemic side effects. And of course, the traditional pathways, nitric oxide, prostacyclin, are refined over time with inhalation or with more subtle interferences with the pathway. So we will have the World Symposium at the end of June 2024 in Barcelona with Valerie, with a key driver of this World Symposium. And we will certainly have more news to share in the future. So thank you very much for your attention. Should I stop sharing?
No, go ahead.
Marc, thank you. That was wonderful. You take something that is so complex and make it so straightforward. So I would like to see if there are any questions for Marc. David, you have a question? Go ahead.
First of all, I have a wow. So thank you for visiting here. And I mean, between the two of you at Powerhouse, this is pulmonary hypertension. So yeah, we're so lucky to have Dr. McLaughlin with us, and glad you're visiting. So two questions. First of all, in the STELLAR trial, was the N big enough to look whether the genetic pathway versus the non-genetic pathway made a difference in the active inhibition?
It's a great
data.
Yeah, thanks for the wow. That's good to hear. And yeah, it was not predefined in STELLAR, but it was predefined in PULSAR, you know, the phase 2.
Right.
So in the phase 2, it's only 104 patients, only 90 had genetic screening, some had scleroderma. So genetic in scleroderma, it's not the same story. But at the end of the day, we have 25 patients with BMPR2 mutations, and the others have no BMPR2 mutations or other mutations. And it's very interesting. The response to these TGF-beta pathway-directed therapies is the same, meaning that it could be beyond BMPR2. So we will try to publish that maybe around ATS this year.
Sort of thinking a final common pathway or something like that.
Yeah.
It's interesting. And then a second question. So with the fen-phen era sort of maybe behind us, but tell me maybe how that interacted in this episodic, momentary way. And, you know, I'm surprised by the serotonin data, but how did that cause so much permanent lethal pulmonary hypertension?
Yeah, that's important. You know, you take 1,000 patients exposed to fen-phen, and only a handful will develop PH. So it was an obvious risk factor, but it was not enough. It's like my rats, the second heat, third heat. It was not enough. Obesity was not the comorbidity explaining why these patients developed pulmonary hypertension. In France, most of the people who used fenfluramine derivatives, they were not obese, but they were rather slim, and they were taking it to be even slimmer. I mean, young patient wanted to be in good shape. So at the end of the day, we do not understand everything about fenfluramine exposed pulmonary hypertension or driven pulmonary hypertension. But the first thing is that you have more common valve disease than pulmonary hypertension. So it really flags serotonin. I think serotonin was the driver. But second, we don't really understand why some patients were more prone to develop pulmonary hypertension. When I was younger, I did the genetic studies of the French fenfluramine-driven pulmonary hypertension. They were around 1 in 10 with BMPR2 mutation. So 90% did not carry a BMPR2 mutation. So we don't understand. It really flags serotonin. That's the reason why we were so excited with drugs targeting the serotonin pathway, but it's so complex. And when you decrease in fact, the drugs rodatristat decreases serotonin level. And we know that when you decrease serotonin level, you may have counterbalance reactions. And in fact, with this drug, pulmonary hypertension aggravates. When you block, although serotonin is an obvious target, when you block it, you have more pulmonary hypertension. So that's fascinating. But now we don't wish to play too much with serotonin until we understand better. So I'm not sure I replied your question.
Told me you already looked at the genetics. They weren't all mutated patients.
Yeah.
Thank you.
Dinesh?
Thank you, Marc. The data is spectacular. I think you really highlighted the best and right side. Oh, thank you. You really highlighted the bench to bedside. So I'm looking at the data. I mean, the clinical data there's no doubt. You're targeting activin TGF-beta, which is really critical master cytokine for our disease, scleroderma. And then you're seeing more telangiectasias. So which is quite a surprise for me. But then you highlighted, and I need to go back and, you know, I've never thought about the pathways associated with telangiectasia. So that's an interesting aspect. In the CTD patient, which was only 14% in the phase 3 trial, I don't know how many were scleroderma. Was there any worsening of the disease?
Yeah, no, it's a great point. I was expecting that point from you. So scleroderma were underrepresented in PULSAR and STELLAR, but they will be well represented in Hyperion and Zenith. So your question is still open. To the best of my knowledge, the scleroderma did as well in terms of PVR improvement, maybe slightly less, but as well broadly. they improve their walk distance, they decrease their NT-proBNP. So there is no safety signal. But let me open a little bit more to BMP9. BMP9 is not in the traditional targets we present when we present activin receptor type 2 ligand trap. We always mention activin A, we always mention activin B, we always mention GDF8, myostatin, and GDF11. We don't mention BMP9 and BMP10, but BMP9 and BMP10 are trapped by this agent. And when you look at patients with chronic liver disease, BMP9 is produced in the liver, and they have no longer BMP9 production, and they develop spider navy. So BMP9 and telangiectasia, for me, it's an obvious link. So maybe in scleroderma, we can partner on that. There is certainly a discovery to make, but certainly in scleroderma, maybe telangiectasia will worsen. In fact, it's difficult. We need people like you or your dermatologist colleagues to monitor the telangiectasia spread in patients with already quite an amount of telangiectasia. What is obvious, what was obvious in Brazil, young ladies who care about themselves, they realized that they have spots on the face and they complain. And then in Germany, then in France, then in the US. So that's scleroderma, it's a very important condition for this.
And another quick thought is that, I'm thinking about, as a rheumatologist, all the immune check inhibitors that came and then the rheumatic issues that happened. Is the drug FDA approved now? Well,
The PDUFA date is March 26th.
but this will get FDA approved. But as you start treatments with idiopathic PAH, we have now put together a very large nail fold capillaroscopy unit with a new faculty, where we bought this fancy machine to look at nail fold. It will be interesting to see what are the changes that are happening in the patients that you initiate this therapy out here. We can prospectively look at it and see what are the changes that are happening in these biomarkers and nail fold capillaries. It'd be fascinating to look at it.
That's a great idea. And I think you should do it. And you should also relate that to the magnitude of efficacy, because maybe you need to have some effect on the angioproliferation to be meaningful in the lung. So the balance, always the balance.
Thank you for that fantastic presentation. It's really eye-opening, and look forward to the patient.
Up until now, pulmonary hypertension has included multiple agents, and where does this drug sit as far as like the ranking of its effects on the natural history of PH, and will there be an era where we're actually backing off on some of these other agents? This agent is injected on a scheduled basis, but not continuously, as I understand it.
Yeah.
Right? And so it gets you out of the era of having to have a continuous line, maybe, to take off some of those other agents.
No, it's a great point. Clearly, some of the drugs we use in PH are not pleasant to receive, either because of the mode of administration or because of the side effect profile. So it's clear, and we were discussing that yesterday over dinner. It reminds me a little bit of the asthma treatment, where we try to simplify the treatment schedule in order to make the treatments which matter more acceptable in the patient. So first point of my answer, where will it position? Right now, we cannot position it up front. We cannot position it too early. It should be in patients who are already receiving, I think for France, at least two drugs. At least two drugs, we will see in the States. But that's why that will be the thing. Then what do? We don't know the very long-term safety of this agent. By definition, we see over time more side effects, which are acceptable as compared to what we used to have with the other agents. But if nasal bleeding is followed by other type of bleeding, etc., the first thing is that we treat less and less our patients with anticoagulants. In the old days, all of our patients were on anticoagulants. Now we refrain, we don't use it anymore. And then will we be able, for example, to wean patients off disturbing prostacyclin infusion or things like that? That's something we have to develop in in well-designed, either randomized controlled trial or at least well-designed real-life evidence or real-world evidence type. But your point, I'm not sure I covered everything, but we need to improve, and Valerie will be in charge of the treatment algorithm at the World Symposium, so she has headaches now.
It is an entire group that is in charge of the treatment algorithm. Well, I'm sure we could ask Dr. Humbert questions all day long, but we're at the top of the hour, and I'd like to thank everyone for attending. And Marc, thank you so much for the wonderful presentation. It's a pleasure to have you here.
Thanks.